Today we have with us Dr. Rajiv Jalil. He'll be taking a lecture on the topic management of chronic pancreatitis. So that's something I'm not sure whether we might be managing in a long-term process, but then someone who might have to be, we have to have an approach to know how much to manage to some extent at the medical level, and maybe theoretical knowledge for PG level. So, Sir Dr. Rajiv Jalil is Associate Professor in the Department of Gastroenterology, Christian Medical College, Vellore. His areas of interest is in bariatric endoscopy and GI motility disorders. Sir, thanks a lot for agreeing to take this lecture for us. If any doubts, please feel free to ask Sir directly or put down the chat box. We'll soon be uploading this lecture in our Department of Medicine YouTube website. So, over to you, sir. Thank you.
Okay. Good afternoon. Thanks, Anju, for the introduction. And I would like to thank the Department of Medicine for giving me an opportunity to deliver this lecture. So the topic of discussion for today's medicine meeting is management of chronic pancreatitis. So we'll start with a clinical scenario. There is a 38-year-old gentleman who presented to emergency department with a history of recurrent abdominal pain for about past 6 months. Occurs once in 6 months for the last 5 years. So recently his pain frequency has increased for the last 3 to 6 months, and this time he has presented with acute onset severe epigastric pain radiating to back that is relieved on leaning forward with associated history of vomiting, and there is a history of significant alcohol intake is there, and for each episode of this pain recently he has been recurring hospitalization, and for records, when we reviewed the records, it had showed that there is increase in amylase and lipase level, and when an imaging of pancreas was done, that abdominal imaging showed a parenchymal calcification of the pancreas with edema, surrounding edema, and a dilated PD. So looking at this clinical scenario, there is no doubt that this is a patient with who was presented with chronic pancreatitis and who has a acute attack. So this is like an acute on chronic pancreatitis. So what additional information will you ask this patient coming to the emergency department? So first we need to know the precipitating factors. So is the alcohol, because this patient has been having the abdominal pain for about past 5 years. So has obviously the doctors would have advised, his physicians would have advised him to stop alcohol. Does he have precipitating factors like all ongoing alcohol intake? Is there a binge of alcohol over the last few days? There is associated history of smoking, history of loss of weight, loss of appetite, early satiety or abdominal fullness. So because of this fear of eating due to pain, patients tend to eat less and they are prone for malnutrition. Also, there could be because of this early satiety due to pseudocyst of pancreas or abdominal fullness. So this also will cause decrease in appetite, and eventually this patient will have loss of weight and malnutrition. So the other history which may give some additional information is probably the complications of chronic pancreatitis, like history of steatorrhea. So the history that we can obtain is does the patient have history of any passing oily stools? Does the stools float in the water, or is it difficult to flush out? And associated history of any recent worsening of diabetes mellitus. So always, whenever this patient presenting with acute abdominal pain, though the diagnosis is very evident that it is a chronic pancreatitis, the other differential diagnosis like intestinal perforation, acute cholecystitis, myocardial infarction, all this differential diagnosis should be considered in mind. So the X-ray, the plain X-ray had showed there is calcification at the level of pancreas, that is level of L2, L1 vertebrae, and there is the CT done, CT abdomen of this patient shows there is a chunky calcification and atrophy of the pancreatic parenchyma. So coming to the topic, so what is the definition of pancreatitis? Pancreatitis is a recurrent inflammation that leads to irreversible progressive fibrosis and damage to the gland. This is characterized by uh, abdominal pain, that is the most severe symptom and the most commonest symptom in a patient with chronic pancreatitis. And the damage to the gland could be manifested by steatoria in the form of steatoria in exocrine insufficiency or diabetes mellitus in endocrine insufficiency. The commonest etiology in the Western countries is alcohol intake, while in Indian subcontinent there is no definite etiologies identified in most of the cases. Still, the incidence of alcohol is on a rise, and the other etiologies that needs to be considered in a patient with chronic pancreatitis is hypercalcemia, metabolic causes like hypercalcemia, hypertriglyceridemia. There is tropical calculus pancreatitis, hereditary pancreatitis, and obviously there is autoimmune pancreatitis. There is type 1 and type 2, and they may present with the features of jaundice. And this fibrotic changes that occurs in a chronic pancreatitis are present even before when we see the calcification and the duct strictures. So what are the symptoms, symptoms and complications associated with pancreatitis? So definitely abdominal pain is the commonest symptom. Nearly 100% of the pediatric cases and 80% of the adult cases has presented with the history of abdominal pain. As we all know, it is pancreas lies transversely across the abdomen, behind the stomach, and in front of aorta. So the inflammation of pancreatitis causes pain by direct stimulation of the nociceptive fibers in the posterior abdominal wall, which is innervated by the ventral branches of intercostal nerve. So the other theory for the pain is a referred pain by the convergence and the close relationship of sympathetic innervation of pancreas and segmental innervation of joint muscles and skin in the lower thoracic spine. The other symptom could be it's like symptoms of steatoria, like I said, oily stools. Then the possible complications could be diabetes mellitus, which is seen in about 30 to 50% of the patients with pancreatitis. There could be pseudocyst of pancreas following an attack of acute or chronic pancreatitis, will present with an epigastric fullness or a mass palpable in the epigastric region, early satiety. There could be a bile duct or duodenal obstruction because of the infiltration of neutrophils to the bile duct, or by an extrinsic compression of the pseudocyst. There could be a pancreatic ascites or a pleural effusion because of a pancreatic duct disruption or a pancreatico-pleural fistula. Pseudoaneurysms are which is a rare presentation that may present the pseudoaneurysms of splenic artery. Splenic artery is the commonest site that pseudoaneurysm occurs. So a patient who is a chronic pancreatitis patient who presents with a hematemesis or melena, so the differential diagnosis that should be kept in mind, or the diagnosis should be considered the rupture of a pseudoaneurysm. Splenic vein thrombosis and pancreatic cancer are the other complications. Pancreatic cancer is found to occur in less than 4% of the patients with chronic pancreatitis. So like I said, the abdominal pain is present in about 90% of the patients with the chronic pancreatitis, and its incidence is 100% in the pediatric age group. This affects the quality of life and produces burden on the health system as well as economical burden on the family members. The pain pattern and severity does not correlate with the morphological extent of the disease. Usually when they develop a severe calcification, the patient pain severity may in fact decrease because of the burnout. The pain of the abdominal pain in chronic pancreatitis could be of two types. It could be that is type A and type B. Type A pain could be a severe intermittent pain, and which is could be because of an acute attack. And type B pain is a continuous persistent pain that is usually seen secondary to pseudocyst. And our Indian population, the pain pattern is considered to be, that is common as intermittent type of pain. So what are the mechanism of pain? So there are two theories of two mechanisms that has been considered for pancreatic type of pancreatic pain. So that is increase in intraductal pressure or the neural mechanisms. So the increase in intraductal pressure because of a stricture or a stone or causing an obstruction, this increased pressure leads to tissue ischemia. So the studies have shown that also these patients with chronic pancreatitis tend to have decreased blood flow, and there is subsequent pancreatic cell activation, and there is subsequent generation of reactive oxidative stresses. So the neural mechanism, this has been a study that is published in 1988, which is done by Bachman et al. So they looked at the surgical specimens of the patient who has been underwent surgery for chronic pancreatitis, and this has been compared with controls. So this study, they showed that the mean diameter of the pancreatic nerve were increased in the patients with chronic pancreatitis. There is invasive invasion of the nerve by focus of inflammatory cells were noted. There were ultrastructural changes were noted, that is the Schwann cells were seen to be separate from the interposed endoneural connective tissue by a basal laminar membrane. And also there is found to be damage to the individual nerve, edema of the nerve bundles, and damage to the perineural sheath were also noted in this particular study. So uh, this graph shows that graph shows that the diameter of the chronic pancreatitis patients with chronic pancreatitis, the diameter of the nerve is statistically significantly higher. Diameter is larger in patients with chronic pancreatitis, and the mean area of tissue served per nerve is less in patients with chronic pancreatitis when compared with patients with control. And all these findings of this nerve alteration are found predominantly in the head region of the pancreas. Other than this, the local causes of pain are the inflammation like pancreatic pseudocyst, obstruction to the bile duct or the duodenum. And if there is a patient who has been having intermittent episodes of pancreatic type of pain, and a recent worsening of pancreatic pain with loss of appetite and loss of weight, the development of a pancreatic cancer should be considered in this group of patients. Coming to the main topic of this lecture, the management. So the management consists of management of pain of chronic pancreatitis, management of exocrine insufficiency, management of endocrine insufficiency, mainly type 2 diabetes, that I will not be talking about it by itself. It's a topic, and the complications of chronic pancreatitis. So coming to the management of pain, the first and foremost is to identify the precipitating factor. So is there an ongoing history of alcohol intake or smoking? So patients should be advised to stop, and if it's difficult to stop alcohol intake, they should be given consultation with the psychiatrist for a rehabilitation and de-addiction. So stopping the alcohol has found to be the abdominal pain, the recurrence of abdominal pain is found to be disappear in patients who stop alcohol intake. The deterioration of pancreatic function, the exocrine as well as endocrine function, are gradual than patient who has ongoing alcohol intake, as well as the death rate in patients who have stopped alcohol consumption in patients with chronic pancreatitis has been found to be low. So when this is a study that compared alcohol related chronic pancreatitis with non-alcohol related chronic pancreatitis. So patients with alcohol related chronic pancreatitis had significantly more pain, recurrent attacks of pancreatitis. There was a incidence of pseudocyst and exocrine insufficiency, and the rate of annual hospitalization was more in this set of patients. However, the cumulative risk of diabetes, the calcification, the need for surgery, and overall survival was similar in patients with both alcohol-related pancreatitis and when compared with non-alcohol-related pancreatitis. So dietary therapy. So dietary therapy, this is debatable. It's like, but some evidence say that it's like the patient should be advised to take small volume frequent meals, avoid oily or fatty meals. So should encourage them to take high protein diet, antioxidant rich diet like fruits and nuts, and especially should undergo a folate supplementation in patients with alcohol related chronic pancreatitis. So how do we manage episode of acute episode? So this is the WHO ladder for management of analgesia in patients with chronic pancreatitis. If it is a mild type of pain, can be given with non-opioid drugs, acetaminophen can be given. But if it's a moderate, should give weak opioids like tramadol, codeine, dihydrocodeine, or buprenorphine. So and if it is severe, advise strong opioids, morphine, oxycodone, pethidine, or fentanyl. So there is always what we do in our department is we if the pain is mild to severe, we give them tramadol injection, and if it is not being tolerated, we start them on fentanyl patch. So what are the aspects of long-term medical management? One of the drugs that is a neuromodulator that is used is pregabalin, which is an anticonvulsant with broad spectrum analgesic and anti-hyperalgesic properties. This drug binds to the voltage gated calcium channel at the alpha to delta subunit and inhibit neurotransmitter release. So this drug improves pain by inhibiting central sensitization. We usually start with a dose of about 75 mg once daily in the night, and then subsequently according to the tolerance of the patient, and we increase the dose up to 150 mg in the night. So the pregabalin is as a neuromodulator that reduces the pain in patients with chronic pancreatitis. This is a randomized controlled trial which has showed the efficacy and tolerability of pregabalin as an analgesic in patients with chronic pancreatitis. So when the study, they compared the patient's pain score, and they were given daily diaries for pain score, and when compared with the placebo and the pregabalin at 3 weeks, there was found to be a significant reduction in pain in this patients who were treated with pregabalin, and the adverse effect associated with pregabalin were lightheadedness and the feeling of drunk-like situation. These were the two adverse effects that was noted in patients with pregabalin. So one of the major complications of chronic pancreatitis is pancreatic exocrine insufficiency that is characterized by the deficiency of amylase, the pancreatic enzymes amylase, lipase, and protease. So because of this, there is a prevent the normal breakdown and digestion of the nutrients, and this leads to malabsorption. So pancreas has a large functional reserve, and it requires 90% of the pancreatic gland damage needed to cause malabsorption. There are two types of pancreatic exocrine insufficiency, that's compensated and decompensated. So compensated means there is a decrease in the enzyme output, mainly lipase, but there is no nutrient malabsorption. While decompensated pancreatic exocrine insufficiency. This occurs when the pancreatic lipase level drops to less than 10%, and there is clinical steatorrhea present in this group of patients. So 80 to 90% of all patients with chronic pancreatitis develop pancreatic exocrine insufficiency from the second or third decade from the development of the disease. And but the development of pancreatic it's more common in alcohol-related pancreatic exocrine insufficiency is more common in patients with alcohol-related chronic pancreatitis. In this group of patients, they develop within about 5 to 6 years. They develop nearly 60% of them develop pancreatic exocrine insufficiency in about 5 to 6 years. And while idiopathic chronic pancreatitis, the pancreatic exocrine insufficiency occurs after 15 years. So this pancreatic steatorrhea is caused either by the pancreatic enzymes which are inactivated, or pancreatic enzymes are not available due to disruption of the normal process like blockage of the pancreatic duct, or resection or destruction of the pancreatic gland. So the rate limiting mechanism that is in pancreatic is the rate limiting mechanism for pancreatic exocrine insufficiency is the decrease in the level of lipase. So lipase is the earliest enzyme that is lost in chronic pancreatitis, and there is no adequate pancreatic substitute available for lipase. So when the amylase, there is a deficiency, but the amylase function is taken over by the salivary juice brush water enzymes, and lipase degraded fastest in the lumen. Only 5% of the lipase reaches the ileum. So while 20% of the trypsin and 35% of the amylase reaches the ileum. So also there is a decrease in bicarbonate secretion that leads to increase in the pH of duodenum, lead to inactivation of lipase. And like I said in the earlier slide, the clinical malabsorption occurs when lipase level drops to less than 10% of the normal quantity. So the pancreatic enzyme secretion is under the loop feedback loop control of cholecystokinin. So the cholecystokinin is released from eye cells of duodenum, which is under the influence of luminal cholecystokinin releasing factor. So in chronic pancreatitis, there is decreased serine protease in the duodenum, and LCRF is not degraded. So this will stimulate the pain and the contraction of pancreas and the pain. So this mechanism is prevented by enzyme supplementation. So pancreatic enzyme replacement therapy is one of the main treatment therapy that is available in patients with chronic pancreatitis. So this pancreatic enzyme therapy is available as enteric coated and non-enteric coated. So presently whatever available in India is coated, enteric coated tablets. This coating is acid resistant and it is pH sensitive. And the coating dissolves in the duodenum, and release of enzyme occurs at pH more than 5.6, which is the ideal pH for the enzyme to take effect. So presently the enzymes are derived from porcine pancreas. So the goal of pancreatic enzyme therapy is to restore normal fat absorption by delivering a sufficient amount of active lipase at the right place, that is the duodenum and the proximal jejunum, and at the right time in parallel with gastric emptying of the nutrients. So what is the drugs? The common drugs that we used in our hospital is Sarutan or Cryon, and there is no it is based on individual tailoring of the drugs based on their body weight and severity of disease. So we usually start at a dose of about 500 to 500 units of lipase per kg per meal, and depends on the symptomatic relief, or we increase. I mean, it's like the patient is not getting better, we increase to up to 2,500 units of lipase per kg. So approximately about 25,000 of lipase with each meal, and initially we start for all three major meals, and if the patient is not getting relief, we can add with about 10,000 units can be added with each snack. So when comparing both the drugs, it's like Sarutan, it's the each tablet costs about 11 rupees, and while Cryon 25,000 units of Ppis, that is it's about 70 rupees, and these medicines to be taken along with the meals. So what are the, despite pancreatic enzyme replacement therapy, what are the causes for poor response? So various causes are there. It could be a non-compliance of the patient, low or inappropriate dosing. Other thing, because of the cost, patient may not be taking the medicine. Inactivation of the enzymes in the drug by acid or and or by the protease. So inadequate mixing of enzymes and nutrients during the delivery to small intestine. Also low duodenal and small bowel pH fail to provide optimal condition for digestion of the ingested nutrient, and delayed dissolution of entry-coated enzyme microspheres in the small intestine. So there is some studies showed varying report. Some studies have not showed much of a benefit, but there is a Cochrane meta-analysis of 10 RCTs had did not found to be the pancreatic enzyme supplementation was found to be equivocal. But the problem was that some of the patients had have been continue to smoke, continue to consume alcohol. So there was no patient matching characteristics in this studies. The other drugs that is used in chronic pancreatitis is antioxidants. So oxidative stress plays a major role in the pathogenesis and also causes pain. And it's also found that the serum levels of oxidative stress were found to be elevated in patients with chronic pancreatitis. So there are two major RCTs. One is Bharadwaj et al., which showed that this is associated with a significant improvement of pain in patients with chronic pancreatitis. So this is a study done from PGA. There is another article that has come out from UK, that is Sirivardhane et al., that found that there is not much improvement in pain following administration of antioxidant. So we look at why this divergent reports are there. So in Bharadwaj et al. Series, the predominant etiology was idiopathic, and calcification was noted in about 82% of the patient, and main pancreatic duct dilatation was around 72. And the antioxidant composition was relatively matching. So this Bharadwaj et al., following administration of antioxidant, they found that there is a significant reduction in painful days in a patient in the month, and the requirement of analgesics were also found to be less. While there was they assessed a numeric pain scale in the Sirivardhane et al., and they did not find any improvement. So other factors that the patients in Sirivardhane series were predominantly of alcohol etiology, and nearly 80% of them were continued to smoke in Sirivardhane series, and while the Bharadwaj series only 28% were smokers. So the role of PPIs in chronic pancreatitis, usually PPIs are also like a pantoprazole or esomeprazole are given along with patients with chronic pancreatitis. So the coated drug occasionally not activated in the duodenum, and there is low level of bicarbonate which prevent increase of pH to above 6. PPIs are used to increase the pH. So there is other mechanism that has been there is an endotherapy that has been used for chronic pancreatitis is celiac plexus block. So this is endoscopic ultrasound guided injection of bupivacaine to the celiac plexus, and this is found to have a significant improvement in the patient's pain, also significant improvement in the quality of life. So in a series they found that up to 24 weeks and even one series up to 48 weeks there was a significant improvement of pain was noted in this group of subset of patients. So where else the endoscopic therapy can be used in patients with chronic pancreatitis? So usually the stones and strictures are the of the pancreatic duct are complications of chronic pancreatitis, and this stones can be seen in about nearly up to 70% of the patients with chronic pancreatitis. So whenever endotherapy is useful is the patient with the large duct chronic pancreatitis, and if the stone size is more than 5 mm, they may require this extracorporeal shockwave lithotripsy, ESWL. So endotherapy, the principle of endotherapy is to reduce the intraductal pressure, and that is used in patients with primarily obstructive lesions of a pancreatic duct, like if there is a stricture, pancreatic duct stricture or a stone. So the endotherapy is used if the patient has a single stricture in the head of pancreas. If the patient has multiple strictures or in the body or a tail of pancreas, this endotherapy will not be very useful. So, like I said, the endotherapy should be considered to stop in patients with multiple strictures at the tail or location, and the strictures are dilated using balloon prior to the stenting, and this pancreatic stent usually placed are of 7 or 10 French with ERCP, I mean it's like cycloscope, and the replacement of the stent should be considered within 6 months or if the patient is symptomatic. So, following pancreatic stenting, nearly a successful placement was noted in about nearly 100% of the patients, and immediate pain relief was noted in about 90%, and up to 74% of the patients had 6 months improvement of pain. So there is this series showed that is like nearly for patients with stones, nearly 69 of them had improvement of pain with endoscopic placement of the pancreatic stent, and nearly 70% of the children also found to have this is a similar result that has been found in both the groups, both adults and pediatric groups. So if there is a small duct calculus there and there is a persistent pain is there despite all the medical therapy, it can be removed with baskets or balloon. Like large stones need shockwave lithotripsy. And long-term retrospective studies have shown that up to 60% of the patient has been having lasting pain relief. Also, in addition to breaking of the stone, the ESWL reduces pain by altering the nociception through action of the intrapancreatic nerves as well. So ESWL is done for patients with a stone of more than 5 mm in size. About 1,500 to 2,500 shocks are given in each session. Frequency is about 60 to 90 per minute. Duration of each session is 30 minutes, and this is done with conscious sedation. And the patient will have to undergo repeated sessions till the fragments become less than 3 mm. The possible complications that is present with ESWL, it could be a peri-procedural pain, could be the skin ecchymosis, pancreatitis, and rarely bleeding has been reported. Surgery, the principal surgery that has been advised in patients are for pancreatic ductal decompression. The surgical options can be, it could be if the dilated duct more than 6 mm. The procedures that patients usually undergo are Whipple's procedure, there is Berger's procedure, and there is Whipple's, Berger's, and Frey's procedure. These are the common procedures that patient undergo surgical procedures. And if the duct is non-dilated, then the patients tend to undergo a procedure called Hamburg procedure. So Burgess procedure is resecting the pancreatic head but sparing the duodenum and covering that site with a defunctionalized Roux and vaginal limb to allow the drainage of pancreatic and biliary secretions. And burn procedure uses a pancreatic resection without longitudinal duct insection. So, but leaves a narrow layer of pancreatic tissue here. So the recent advances in this field is a patient who has to undergo total pancreatectomy and islet cell transplantation. So this islet cells are removed, and this has been introduced into the portal vein, eventually lie in liver and tend to secrete insulin. So the total pancreatectomy and islet autotransplantation was studied in patients with in children. I mean, predominantly, I mean, it's like about 53 children in about 409 patients. So in this patient, 85% of the patient had improvement in the pain, and by 2 years, nearly 60% of them could be stopped to could stop the narcotics, and insulin independence was occurring in about 1/4 of adults and half of this pediatric children. So coming to that clinical scenario that we had initially looked at. So when a patient presents with pancreatitis, it's like two rule should look for a complication. Encourage them to stop alcohol and smoking. Patient can be treated with enzyme supplementation, analgesics, antioxidants, and pregabalin. If patient is symptomatically improvement, continue to be on follow-up, and patient should be watched for exocrine as well as endocrine insufficiency and look for any new development of complications. If there is no or the improvement of fever, I mean improvement of the pain, assess the pancreas and pancreatic duct anatomy using an MRCP and a CT abdomen. Assess the MPD. So if the MPD, main pancreatic duct, is dilated more than 6 mm, surgery. If the surgery is not willing, patient can be considered for endotherapy. So if the small duct disease, it's like if the PD is less than 6 mm, continue medical treatment or Hamburg procedure. So what we do in our department is like a patient presenting with chronic pancreatitis, the non-pharmacological measures in advise, encourage them to stop alcohol intake, encourage them to stop smoking. And we start the patients usually on pancreatic enzymes, neuromodulators like pregabalin and antioxidants and PPI. The persistent pain is there, and if the pancreatic duct is dilated, the patient can be considered for an endotherapy procedure, or the patient could be considered for surgery if the results are, patient continue to have pain, and surgery is better surgical results if the patient undergoes surgery at an earlier stage. Thank you.
Thanks, Dr. Rajiv. I think that was a very detailed lecture on how to approach and that for diagnosis and management of chronic pancreatitis. If any questions, please type in the chat box. We'll soon be uploading this lecture on Department of Medicine website. Any questions, you can also mail to metro@cmcl.ac.in. If now any questions, please type in the chat box. So that I think that was a very taken in a very simplified way for us. Just one note, like so pancreatic supplements when given, they're like response wise we do look for malabsorption and also for the stool output.
So usually what we do is stool elastase, it's less than 200 is significant for us, and it's usually it's a symptomatic improvement. We give them a pain diary and to note down the pain diary. So that is something which is very significant. So we look at that. But also with this, we have seen that there is an improvement in the stool elastase level. The other advice test is 20. I mean, it's like 72 hour stool fat, but it's cumbersome.
So we do assess with the stool output consistency being getting better.
We have seen that is like patient stool consistency. They say improvement in the that oily stools and the consistency and consistency has been found to be improved in patients.
So and also when you talked about the celiac plexus blockade, are we doing it?
Yeah, we do it we inject bupivacaine for.
Stents or
Pardon?
Transcutaneous,
endoscopic. US guided.
And people do have a significant relief.
So there is a significant relief. Also. Yeah, so there is a significant relief with the.
And do we have a pancreatectomy as an option? Go for it, and also any auto transplantation.
So that is we have not done that, but it's like it's been done in the literature says that it's like the patients or if it is like a patient has a developing malignancy, or it's like if it's not responding to any of the other treatment patient, it has been considered outside, but we don't do it.
Well, there is a the progression you said is faster in the alcoholic chronic pancreatitis than in
Yes.
idiopathic. Then, and then the outcome is also
Yes.
they do worse than
Yeah,
the.
so that is what it's like. One of alcohol abstinence as well as the smoking. This is incidence of cancer risk is high. The progression of disease is also high, and the development of steatoria, that is exocrine insufficiency, is also high in patients who's on ongoing alcohol. But studies does not show that definite development of diabetes mellitus, that is the endocrine insufficiency, that is not found to be very and the incidence of frequent hospital admission and the duration of admission and the recurrent attacks also high in patients with it's very significant in alcohol. I mean, alcohol abstinence is very significant in chronic pancreatitis.
What do we talk about this tropical and fibrocalcin?
Okay, so that is comes in the idiopathic type of this thing. So this tropical pancreatitis, it's again reported from South India, but it is tend to be seen in patients in the pediatric or the second or third decade of life. They'll have a severe pain, and their propensity to diabetes is earlier much more in this patients with tropical pancreatitis, and in fact the steatoria develops much. That is the difference in this patients. Again, it's like of late the series is showing that is like that age group, that onset of age group in tropical pancreatitis that has been increasing. It's like which was seen in about the 20s, and so now it's going up.
Any further questions? Thanks again, sir, for agreeing to take this lecture for us. And I think if no further questions, we'll wind up for today.
Thank you.
Thank you, sir.
Thank you.